Good afternoon. This is Kevin Warling at Envision, New Mexico at Studio Envision. And so today we are presenting our School-Based Health Center Quality Improvement Initiative, Part 3 of our technology series, Health Information Technology Pre-Implementation Strategies. And like I said, this is Kevin Warling. I'm Systems Analyst here at Envision, New Mexico at the University of New Mexico. And I am certified as a software support and implementation support specialist from Midland College in Texas. And that's something to take note of. If you know somebody who's getting into IT or looking into health information technology or just looking to expand their knowledge on this sort of thing, it's a very short certification program. And if you're interested in that at all, or if somebody is, I'd be happy to pass on some information about that. It's one of those extremely understaffed areas in information technology, and it's absolutely critical that we have more and more people who can support these systems. So just putting that out there. If anybody's interested, then please send me an email or give me a call. And at the end of this slide set is my information, email, as well as on envisionnm.org on the staff page. So let's go ahead and introduce who we have in our room here, and then we'll see who else is out there online.
John Martinez, Envision, New Mexico, Quality Improvement Coach.
McKean Starf, Envision, New Mexico, Quality Improvement Coach.
Welcome, John and McKean. And who do we have out there? I have Hadith Ramirez, Tilly Crawford, and Carrie. I have you as Carrie Peterson, actually. Is it Carrie Hopes? Did we lose you? Looks like you're both muted. Looks like you're both here, though. If you need to unmute, it's *#. I am showing you still as here, and I have you written down, so we're good to go.
This is Heidi from Basalt, Colorado.
Welcome again, Hadid.
Thank you.
Okie doke. Let's go ahead and get started. And I do want to let you know we only have a few people on, so feel free to jump in at any point with questions. It's fairly real time over this phone line, so you can jump in and interrupt me at any point. So just a slide set on our CME policy and disclosure. I have nothing to disclose, any financial relationships. Our objectives today mostly are on outlining. You're going to be able to outline the steps involved in preparing an organization for implementing an electronic health record system, and we're going to get a little bit into outlining steps involved in actually implementing the EHR system. It's really, most of this is really related to preparing your organization for an EHR. So our part one was on health information technology history. And if you were there, if you weren't, just a quick summary. We went over interoperability of EHRs, practice management systems, patient portals, billing systems, registries, everything you need to connect with in healthcare. We went over the standards that are defined by the ONC, and there are now requirements of EHRs to be certified. And we also went over kind of a way to find out whether it is certified or not. Interoperability. Interoperability removes barriers. The standards remove barriers to interoperability. We also went over just a brief timeline, which is a handout that I don't believe is on this particular webinar, but I can get that to you if you're interested in. More of interest kind of thing than anything. But it does give you an idea of how young EHRs are. We're really still in the infancy. And also expectations. What do we think HIT is going to do in the near future? Part two, which we did last month, we went over HIT infrastructure. So essentially, what do you have in your in-house, what kind of computers, network systems, as well as what kind of IT support people do you have? Do you rely on consultants? Do you rely on an outside person, maybe somebody who's off-site? Or do you have somebody in-house? We went over server-based systems that are actually housed in your facility on a server or a server array, and we went over some internet-based systems, which are much more typical for smaller organizations. So before we get into today, did anybody have any questions on part 1 or part 2 of our technology series? Okay, and if you do, please go ahead and chime in at any point. So when you're starting to look at EHRs, and say you've done your research and you have 5 to 10 picked out that you think might possibly work for your facility, what you're going to want to do is put together a request for proposal. And you may have heard of this before if you've done any project management. And if not, then basically a request for proposal is an invitation to vendors to solicit your business in a very specific way. In other words, you're going to outline exactly what you need your EHR to do and what your business needs it to do, how your workflow goes, and you're going to send all that to these vendors, and they're going to send you a proposal back. You're not necessarily talking money yet, but they may include some base prices and that sort of thing. The main benefits to having an RFP is, first of all, it forces your organization to look at what you really need before you involve a vendor. Because things get pretty complicated once the vendor gets involved. They're going to want to steer you towards what they can do, not towards what you need necessarily. So it's good to have a really good idea specifically written down of what you actually need it to do. Second, it also helps your organization compare your vendors, of course, and understand any project risks that might be coming up. So you get your proposals back in, and you can compare each one of those, and they're going to be in fairly standard formats, so you can compare and contrast what they're able to do for you. There's some general elements of an RFP, and by the way, the next slide will have a link to a website that gives you a lot more detail on this if you want to get down to more detail. But the basic elements are, you want to give an overview of your business issue. What are you looking to do here? You want an EHR, you want it specifically to do what? Give a description of the product services required. If you already know exactly what you need, if you need a practice management system along with the billing system, along with the patient portal, you get the idea. Detailed business requirements. How do you want these proposals to come back to you? What format do you want them in? That'll help you compare and contrast them later on. So I spent a little time on that. A due date. When do you want the proposals back? In other words, if they don't get it back to you by November 30th, then they won't be considered for your organization. The selection criteria. In other words, how are you going to decide what vendor you're going to choose? Your timeline as far as not just when you want the proposals back, but how soon do you want your EHR implemented, and even more detail than that. When do you want it completely implemented? Do you want to do a full rollout all at once? And we're going to go into different rollouts at the end of this slide set as well. So just give them an idea of what you're looking at. How they're supposed to respond to you, via email, a website, by phone, probably not, by mail. Email's probably the best unless you're blocked or anything like that. And of course, a point of contact. You want to specify one person within your organization that will, this is probably going to be your project management person, project manager, but you want somebody who's going to compile all these, or at least the person that all these are going to be sent to. And as promised, there's a couple of resources here. EpicTech.com has a rather lengthy, detailed explanation of what should be involved in request for proposals. I believe they have some templates on there as well, and they're all there. If you do a Google search for request for proposal, you're going to find a lot of them. Try to narrow it down to electronic health records if you can. The HIMSS website, it's a .org. They're a nonprofit. They have to do with health information technology and the credentials that I was just talking about at the beginning that I have. You do have to be a member to access documents, but it'd be worth contacting them if you're not able to get what you need from the Epic Tech website. That's kind of a backup. Of course, you can always email me as well. I do have access to those documents if needed. So some other EHR pre-implementation considerations. So of course you're going to do an RFP at some point and send those out to your possible vendors. The main consideration aside from that is you want to involve your stakeholders. And by stakeholders, we're not talking shares or stocks here. We're just talking about who's involved in using this EHR in the future. That can go all the way from a physician down to the patient. As you know, there's patient portals that are becoming more and more popular and are going to be essential in the next 5 years or so. So it's a good idea to have a physician champion, if you possibly can find one, who will be the person who's pushing for the EHR to happen. This person wants it to be in their facility. They're kind of up on technical issues and technical ideas and what's going on in the world of tech. Possibly a power user, but not necessarily. Just somebody who knows it needs to happen and who is willing to do a little pushing for you. If you can get a nurse to do that as well, that's great. But involve the nurses, possibly patients, maybe just via a survey rather than on your committee. Clerical staff, they're dealing with the billing, they're dealing with scheduling patients. They need to have some say in what's going to go into the CHR. Your laboratory staff, management, typically they're paying the bills. Suppliers, and of course the community at large. Any questions at this point? Pause for a moment. Looks like we had one other person join us as well a few minutes in. Would you like to announce your name?
I think that might be me. My name is Liz Martinez, and I'm with the Laguna Division of Early Childhood.
Welcome, Liz.
Thank you.
Thanks for joining us.
Kevin, just a question. So would the stakeholders be, this is John from Envision, so would another way to think about it, anybody who's going to be touching the EHR or interacting with it? Okay.
Yeah, that's the main idea there. Anybody who's going to have to input data into it, anybody who's going to have to pull data out of it.
Okay.
And what I oddly left out of this list is your IT staff. Maybe because I know you probably don't have IT staff on site, but hopefully you will in the near future. I want everyone to have an IT guy on their hip. So more with stakeholders here. You want to involve them in every aspect of the planning. In other words, how are you going to be communicating these changes? There's going to be some changes involved in implementing an EHR. They might have to do with your processes that occur at your facility, how you actually run a laboratory, how you actually run your front desk. You might have to make some modifications there. So how are you going to communicate all this out to your patients, to your staff, to your nurses, and to the physicians, as well as the community at large? If somebody's trying to contact you and the best way to contact you is now via email, well, you need to put that out there. So you want to also, another aspect of planning, design benefits. What's your plan? The process gap analysis, which what I was just talking about, how you're going to modify your processes to make it work with the EHR system that you have. Now, of course, you want the EHR to be adapted enough to your process, or adapted to your processes primarily. As much as you can, make the EHR work with what you're already doing. But there, almost always, you have to make some modifications to how you're doing your business. Also, policy procedure changes and a learning plan. This is critical, and we're going to talk about training a little bit in the next few slides. But how are people going to learn how to use this EHR? It's a huge deal. The biggest reason the EHRs don't work and physicians don't use them is because they haven't been trained well enough. They don't know how to use it. It becomes more time consuming than doing it on a chart, doing it on paper, and so they just abandon it. So make sure you do your training before, right before, and during the implementation. You also want to have people around who can help retrain, who can answer questions and support the EHR deployment.
Kevin, I have a question. I was really struck by what you said about the clinics changing some of their policies and procedures. Because it's interesting, because when you think about an EHR, you think that it's going to be Superman and come in and make you more productive and help you with all sorts of things. And that's interesting. Did anybody else out there think that, I mean, it's a good point. It's a really important point that the clinics might have to change some of their policies and procedures too, instead of the EHR just coming in and fixing everything. That was interesting to note.
Yeah, I think, did anybody have a comment on that?
I mean, it seems really helpful to know going in that this isn't going to save and fix everything, and there's going to be some changes we're going to need to make to adapt to it, not just that it can be adapted entirely to our processes.
And you're absolutely right, and I can see how that could be striking to anybody who works in a facility, or anybody who's trying to help. A QI coach, for example. There's a very good chance you're going to have to change some of your processes to make it work with the EHR. Now, the idea is if you find a good vendor, if you find somebody who will really work with you and who will modify their product for you, you can probably make it match up with your workflow almost exactly. But you just have to kind of be prepared for the changes. And so you want to put a lot of thought into that. Mm-hmm. You never want to jump into an EHR. And I know a lot of facilities who have, including our hospital. And you wonder if a little more went into that, if some processes could have been kept. Mm-hmm. But that's conjecture. So
it's interesting. That's good. It's good to go in with that attitude.
Just to know you might have to.
Yeah, I save some of the frustration level of the conversion.
If you expect it, then you won't necessarily be as frustrated. So another piece of this that we've touched on is a project manager. It's pretty important to have somebody in charge of the project in general. It may have to be somebody who's, maybe it's the physician champion. I'd probably advocate for it to be somebody else, maybe the IT person. A project manager is ideal. I mean, it's a totally different set of skills than a lot of us have, including myself. And this is a person who can think more generally, who can think for everyone, and who can kind of take everyone's ideas and everyone's needs and compile them, communicate them to your vendor, and bounce it off of them and give feedback to your stakeholders. This person can keep all the stakeholders in mind, not just their own business processes. Say, the front desk person is going to be thinking about their processes, not necessarily the physician's processes or the nurses. They will also be the lead of the project in general, but of the timeline, and be able to modify that as you go. It needs to be somebody who can be fairly flexible. So another consideration is your project cost, of course, and this is what your what your management's going to be thinking about, or your administrative staff, or if you're owned by physicians, then they're going to be thinking about this as well as workflow. How much capital you're going to have to put into this. In other words, you're going to put a new server into your facility and load a EHR system onto that. Are you going to need any new computers? Like we went into in part 2 last month, what's going to be involved here? You need to think all the way from your network system, your computers, any kind of mobile devices, all the way through to the server. And if you're not doing a server-based system and you're going to use the internet to connect to your EHR database, then you need to make sure that you have a good line out, you have a good internet service provider, and that it's guaranteed 100% of the time up. It's very, very important. You can imagine if you're not able to access the internet and that's where all your data is and your patient's standing right in front of you, you're not going to be able to access their data.
I have a question, Kevin. This
Sure.
is McCain. Are there firewalls or anything that might be set up on wireless that would make it, if someone was using a laptop or something that would make it hard to use a internet-based is there anything that's going to prevent it from being easily used?
There are always barriers. I mean, a firewall, you're going to have a firewall on the way. You need to have somebody who's in charge of that firewall who can open that up for the EHR, so you can talk to your EHR. Wireless, same kind of thing. It can be set up a little more secure than a wired situation because it's a little more accessible to the outside world. You may want to cut off wireless, direct wireless communication to the EHR. And that's where your IT support is going to come into play. If you have a network person there, they need to set up the network to be able to deal with that and to be able to be secure enough that your traffic can go through, but somebody can't just walk in and hack in.
There's probably some compliancy issues too with HIPAA with wireless.
I'm not sure. There are some compliance issues with that. You basically just need to have a credential-based wireless system. Like, for example, in our building here, we have a guest access and we have a secure access. Our secure access works just like our wired system. You just have to log in with the username and password onto a domain. There's a guest access that you can access only the internet, and it's locked away. Typically, that's in a different kind of silo, for lack of a better word, and kept away from the secure login, so they wouldn't be able to access. They certainly wouldn't easily be able to access your EHR, and they'd have to be really good at hacking in and really want to.
That's a good illustration.
Let's see. So your capital costs, your licenses. So if you're dealing with a license-based EHR, in other words, do you have to pay for every machine that you load the software on? Likely not with a web-based system, but just make sure that that's in your request for proposal and in your contract.
Kevin, being a guy who's bought a bunch of stuff from salespeople, how confident can you be that the estimates they give you for maintenance costs, for staffing time that's going to be used, is there a general rule of, or how you could find that out? Because I've often found that what the salespeople say and what actually occurs can be often different. So if the people out there in our audience are going to be making the decisions and trying to evaluate these things, just because the salesperson tells you this is what the maintenance costs are going to be, is there any way to really kind of validate that?
Well, if they quote you a maintenance cost, say, upgrades cost this much, or you won't be charged for upgrades, they're just part of the package, that should be outlined.
Okay.
It should be stated in your contract. Now, things like timelines, those can be fairly fluid. That's a little more difficult to say. The vendors, I can't speak for the vendors, but vendors want you to be able to use their system.
Mm-hmm.
So, they're going to want to get you on a realistic timeline. There is a really good resource, the I don't have a really good answer for you, John, but really good resources are Health Information Technology Regional Extension Center, nmhitrec.org. There's a link at the end of the slide set. They're here in New Mexico. There's a regional extension center for almost every state in the nation. Ours is one of the top ones as well. They're great. So contact them. That's exactly the kind of question I would ask them. I keep falling back on them, but they are our resource here in New Mexico. They're kind of it. So utilize them. Let's see. So other costs would be staffing. Your staffing for you're probably okay with your standard staffing. I'm talking mainly IT support here. If you need to add somebody on, add that into your capital costs here. You want to make sure that you can keep this thing running and you can have questions answered on a timely basis. Other things you want to consider before you're actually, maybe before your RFP, but certainly once you get your proposals in, you want to evaluate the financial strength of the vendor. You know, how long have they been in business? Have they deployed a lot of these systems around the country? A good way to kind of find out how good they are, aside from finances, and I'm sorry, financial strength, you can actually ask them directly, how are you doing financially? And they have to disclose it. There's probably other resources out there. I haven't found any yet. But another good way to know if they're any good is the KLAS ratings. KLAS doesn't really stand for anything, but it's based on a name. There's a link at the end of this slide set for them as well, and it's a free site. You can go there and look up your vendor and your product and see what other users have to say about it, essentially. It's actually a really extensive database. And you can also go there if you have an EHR and give a review. So no vendors are associated with KLAS whatsoever, so it's completely consumer-based. So if they had a really bad experience with them, if their customer service is no good, or if their IT support isn't responsive, you're going to find out about it there. Also, you want to consider how this EHR is going to integrate with your current systems. So if you're only buying a billing system, or you're only buying a patient management system, is it going to integrate with your other systems? So if you're buying billing, will it work with your patient management system? Will it talk to your laboratory systems? Will it talk to pharmacies? Will it really integrate to where it does what you really need it to do? And Meaningful Use says it needs to do all of those things. So make sure it can. And if it can't, move on. Get somebody else. This all has to do with interoperability, which is a requirement of certification. Now, considering, and this isn't really implementation, this is more thinking in the future towards when you're going to be implementing. There's a couple of ways to do some testing before you actually do your full-blown implementation. One's called Rollout Testing. And what this is you'll grab a few people, a good cross-section of users who will be using it in the future, and you roll out the whole EHR at the same time that you're using your current system, say a paper chart or Excel documents or whatever you're using currently. So you're going to be doing double entry. This is just for a short period of time, and it's just to kind of see how it's going to go. So you grab a few people, you roll it all out, you load it on a couple of machines, and they start using it along with the paper documents, and you start working out the bugs. So you have these users write down everything that goes wrong, things that are kind of in the way, things that don't work with their workflow, and then you shut the whole thing down after a few days, send all your feedback back to the vendor, and see what they say. Typically, they're going to be able to make some modifications, and they're not going to make all of the modifications to the system to make it work for your processes. Another type of testing, it's similar. but the idea here is you're going to be rolling it out as a pilot group, but you're also going to be continuing on to the full implementation. So it's not like you're going to roll it out and then pull it back. You're going to go ahead and roll it out, unless there's huge problems, of course. Then you're just going to stop and start over. So the same kind of thing here. You get a pilot group. You get your super users down to people who aren't so good with computers, and have them start using the system in a very limited way. So maybe just one module. If you're buying a full-blown EHR, maybe you're just going to start using your billing system and see what kind of issues you come up with. So a test in the real world with just a few people so you can kind of work out the bugs. You're probably going to be doing double entry at this point as well, but not for long. And I wanted to mention super users again. If you haven't already defined or found these people in your organization, find them. Especially if you don't have an IT person on staff. You need somebody who can speak the language, who can kind of speak IT, and who's also good at not only finding problems with systems, but with actually breaking systems. They'll push it to the limit to where, oh, here's a huge bug that's going to get in the way down the road, and you can give that feedback back to your vendor. Now, as far as how to roll these things out, there's a couple of methods that we learned about. The Big Bang implementation versus the phased. For either type of these implementations, training and support are paramount. And I know I sound like a broken record, but this is really the most important thing. So you want to train well before you roll out your system. Once you've done your RFP, you've chosen your vendor, you're starting the process of getting everything modified and contracts are being signed. You know what you're going to do. Have the training begin then. This is well before the EHR is actually rolled out, in use, and even all the decisions are made. But start training on it then. You're going to want to retrain right before implementation. So however you have to do it, the weekend before or the week before, very, very soon before it happens. Don't leave a lot of time between that training and the implementation, or your trainees are going to forget half of what they learned. And then, very, very critical, as this is being rolled out, have extra support staff available for that period. Because when somebody just starts using a program, even though they've been trained, they're going to run into something they either forgot, they don't want to mess something up, other people aren't afraid to mess something up, and so they will mess something up. You need to have extra people to fix those problems and to answer those questions. So that may be somebody on staff, and that may be a person at your vendor, a support person at your vendor. So you can see why it's so important to have support written in to your contract. So the Big Bang rollout versus the phased rollout. The Big Bang rollout is all users, all modules, all equipment, all at one time. You can imagine you're going to need to have every duck, goose, and everything else in a row before you do this. This means you need to have your server in place if you're using a server system. You need to have your network upgraded. You need to have all your desktop machines upgraded. Any mobile devices need to have been purchased already. All your pre-training needs to already have happened. This can work for some organizations, but you need to be really good at planning, and you need to have a really excellent project manager. The pros to this kind of implementation is the disruption in your system, in your facility with your staff is much shorter. Assuming it goes smoothly, it will be shorter. If your facility isn't really in a good position to do this kind of rollout, then I would do the phased. There's no need for linking your old system with your new system. Say you have an old EHR or you have a paper-based system, you're not going to have to do double entry, at least not for long. You may want to anyway, but certainly once you know it's working, you're going to stop doing double entry. There's only one system to support, of course. The cons would be it's a very high risk. If you go live with a big bang, then in 2 weeks, if the whole system crashes, your system can't handle it, your users are having too many problems, maybe they weren't trained well, or they're just having issues and they're not entering things correctly, and if you have to shut that system down, you're in trouble. You're going to have to then convert everything back over to your old system so you can use that for a little while they fix the problems with the new system. It requires comprehensive planning. You need to know everything that's going to happen in the coming months before it happens. And of course, mass training is required. You can imagine in a hospital, you're going to have to train everybody from your front desk staff to your nursing staff, to your physicians and laboratory staff, X-ray technicians. Every single person is going to have to be trained at the same time. So you need to make sure you have facilities to be able to do that and coverage so you can take people off the line and train them. The phased rollout is just one or two groups at a time with the specific modules that they'll be using and just the equipment that's involved with their use. So it may just be, well, you're going to implement your practice management at this point. So not the laboratory module, not your billing system, et cetera. So it's only going to be a few people. And it may not involve all of your equipment as well. So if something goes wrong, you can pull all that back and the damage done is much less. In other words, the entries that you made into the HR system already, you can fairly easily pull out and put into your old system, go back, fix your bugs, and then try again. So the pros, you can progressively adjust your strategies, implementation, timelines, everything, a lot more easily. You can do more focused planning, so you can focus kind of stage at a time, which a lot of us work a little better that way. Not everybody, though. Disruptions are isolated, basically what I was just saying. In smaller groups of users are affected. So it's not like you went live, the whole thing failed, and then your entire organization is just down on the whole system. Attitude is a big factor here, so it's not something to gloss over. If going live and having to pull back from that really can disrupt the process, and people who were on board with the system before may not be so anymore. Cons. You do have to maintain two systems, the old and the new, at the same time. So if you have an old EHR or a paper system, you're probably going to be doing a little double entry. Some users in the laboratory, say, are going to be using the old system, and the people who are going to be using the one rollout module are going to be using the new system. So there may be communication issues there. So you're going to have to work those out. There is a risk of stagnation as well. You may have one implementation piece go fine, stage 2 doesn't go so well, so you have to pull back, fix those problems, and start again with stage 2. People who are waiting in the stage 3 group are going to wonder what's going on, what's the problem, and they're going to start, losing the good attitude. So good communication is just critical here. So another good reason for having a point person, a project manager. And there's need to correlate information from both systems as well. I basically talked about that already. There's a couple other things to think about. There's a command center concept. A lot of this is for large facilities like a hospital, large physician practices. If you have a command center with your project manager there and all the kind of head people who are involved, your whole committee, that they meet there once a day to kind of go over what's going on, what problems are happening, what the next steps are. It's very helpful. In a small organization where you have, 6 to 20 people, you don't necessarily need that. You just need somebody to go to. You need one person who's compiling everything, one point. Before a large organization, this command center sounds very high-tech. It's really probably just an office of maybe the project manager where they meet for 10 minutes in the morning. But it can serve as the project help desk as well as the meeting place. So you might have your IT support staff in there, or at least somebody who can transfer you out to those people. It's something you want to consider. A lot of change fatigue language has been going around lately. You're going to be doing a lot of changes, and we all are in healthcare regarding information technology because of meaningful use and because of the healthcare law. And we're going to get there, but the change is painful. It's hard to get through, and people don't like change typically. They like doing it the way they've always done it, and change is hard. So there's a couple of methods. One that we do here at Envision New Mexico quite a bit is the Plan, Do, Study, Act method, apparently without a space between study and act. The PDSA form. That's actually located on our website. If you haven't been there recently, this is what it looks like. Go to the Tools and Resources page. I did include it as a handout, but the fillable version, just scroll on down here. Where are you at? Under School-Based Health Centers, the PDSA Quality Improvement Activity Record. And you can download that. It's a Microsoft Word document, and it is fillable. We're hoping to make that actually a PDF, so it'll work on everybody's machines in the near future. But that's where that is. If you can't find it or can't remember where it is, email me and I'll get it to you. The other one I found, though, that I thought was kind of interesting is a six-step method that actually came up in some of the studies I was doing. It's fairly similar to the PDSA, but it's got many more steps. So record and classify, assess, plan, build and test, implement, and then close and gain acceptance. So it's another method that you might try out. Let's see, it is located at, it's a Wikipedia link, but it has some good description of how this works. So if you're interested in an alternative to the PDSA, that might be something to look into. So now the PDSA, I will say, we use this at Envision, and it works. If you can narrow things down enough, and this is not my area of expertise by any means, though I do have two coaches in the room, but if you can narrow it down to just one specific goal, then it works really, really well. So if you have any questions about that, please contact us, and we'll help you out with that. So that's the end of my slides. I do have some resources here. The Healthcare Information and Management System Society, that's that .org that I was talking about, that you do have to be a member in order to get their resources. I don't believe there's much charge, if any. So mine was a bit gratis because I was certified. So the KLAS research, that is the place to go to see reviews on EHR systems, other customers, and what they thought of it. The EPIC, that is your RFP information from the very beginning. Sorry, these are a little out of order. And then our Extension Center at the bottom of this page, nmhitrec.org. Please go there, call them, bother them. They are your resource here in New Mexico for how to achieve meaningful use, how to comply with the healthcare law. PDSA is on our site, and the six-step change management as well. So at this point, has anybody joined us who has not announced their name yet? and it doesn't appear so. Any questions or discussion?
And I just have this is John again from Envision It, on the hit rec people, or high tech, REC. I've met them at conferences. They're really easy to talk to. They're not super high techy, so for us normal,
Most of them are
average technical people.
Yes, absolutely.
They're really easy to talk to, so don't hesitate.
That's a really good point. I went to there was a conference they had earlier in the year, and I went to it, and just here in Albuquerque, and they had a few vendors there, and that part was kind of interesting. But what I found was most interesting was the people who actually work for the hit rec, and they do have an IT, at least one or two IT people there, and their main guy, and I'm sorry, I cannot think of his name, but he was hilarious. Very easy to talk to, and yeah, he's a tech guy, but he speaks English as well as tech. So he's a really good resource. Everybody there is really cool and really nice to talk to, and don't hesitate to contact them about this sort of thing. If they don't know the answer, they're going to get it for you. That's what they do.
Yeah, and they really want to help.
They do.
Their attitude was fantastic.
They do. They were the very first, I don't want to say this wrong, they're at the forefront of all of the hit recs in the country, and I believe one of the first national registries or state registries that was set up in New Mexico that would actually connect to an EHR. They're really interested in getting New Mexico online and getting everybody pushed forward towards meeting meaningful use criteria. So that's a really good point. Other questions or anything that's come up in your facility that regarding EHRs or thinking about any new EHR systems?
I have a question, and I think this applies to Carrie and Tilly. I think this is great, and the rollout for a larger kind of healthcare group or clinic is great. But so for Carrie and Tilly, there are two people basically. There's a coordinator and there's a provider. So thinking about it in the kind of big bang versus what's the other?
The
phased one. Would you have a suggestion in terms of what the best way to do it for such a small group would be?
For two people, I would probably go ahead and do a big bang. There's a little bit to consider there. Obviously, the number of people would say, yeah, go ahead and do a big bang. Now, if there's many, many, many modules that you're dealing with, those two people are going to be fairly overwhelmed with trying to learn 5 different modules all at once. So that would be an argument for phasing it a little bit. So the modules would be the driving force in the decision there, I would say.
Okay.
But talk to your vendor. It really depends on what you're doing. If you're just doing a practice management system and that's it, and it's one module, roll it out.
Okay.
Definitely. But make sure you get your training from the vendor. They should provide that for you. Probably on site, hopefully on site, but it could be some online learning as well. And get your questions answered before you roll it out. You want to be comfortable with it. You want it to succeed.
And are you aware of training that Welligent has for their EHR?
Welligent would be through Apex.
So it would just be through Apex?
Yes.
Okay.
Yeah, that's how Welligent, from what I've been able to find on Welligent, that's how they work. They find a kind of a subcontractor or a vendor that's local, and they redistribute, they request modifications. That subcontractor, like Apex, would do the training, I think. That's a good question.
That's what we've heard too, but I didn't know if you knew something that we didn't. But yeah, it sounds like that sounds like what Mike has been telling us as well. Oh,
okay. Yeah, I believe it would go through them first anyway. That's how Welligent kind of operates.
Carrie and Tilly, do you have any questions for Kevin while we have his attention?
And if you can't think of anything now, my email is on this slide right here, bottom right corner. I think it's on the slide set as well, but if not, go to our website or Ask McCain and just send me the question. I'll do my best to get the answer for you, or find somebody who has it. And we're looking a little bit more into Welligent and how Apex works with them. And how to kind of turn that into a full-blown EHR system. That process is a little bit just kind of getting started, but it could move fairly quickly. Certainly hope it does.
Hey, this is Carrie. Could you hear me a while ago when I said something?
No.
No, okay, our phone was technical problems here. So what I stated was, no, we didn't really have any questions, but what we were thinking was perhaps we should be doing like the getting the scheduling through Welligent up and running first before we transition into the actual patient charting and documentation.
I don't see a problem with doing it that way. Is that kind of what you're getting at?
Yeah.
I would think that would work just fine. That's essentially you're phasing out your rollout. You're phasing your rollout that way. That's what most places are using right now. Am I correct? And then they're going to turn it into an EHR system?
For Welligent?
Yeah.
Well, they use it for their billing usually,
billing.
but not necessarily for their scheduling.
Oh, for scheduling.
Yeah.
Oh, okay.
Does anybody use it for scheduling, McCain?
Not that I know of. If they have an EHR, that's what they would use.
Okay.
But I think you're right. I think maybe it's a good place to start, especially since we're kind of on the forefront of this, just to see, how it works, and especially when you guys get your new equipment and stuff, just to get used to using it regularly.
Okay.
And it means that Tilly doesn't have to carry around the appointment book to every clinic with her, at least once
Right.
you feel, at first she probably wants to do both, but then once you're comfortable with it, that's something that, would cut down what you're schlepping around with you.
Right. Which sounds good. Okay. We didn't really have any other questions then. I mean,
That's no problem. And when you come up with them, just send them on over, and we'll get them answered for you.
okay, thanks.
How about you, Hadith and Liz? Any questions or thoughts?
This is Heidi. Oh, I'm sorry, Liz, go ahead.
No, go right on ahead.
Okay. In Basalt, we have a very specific challenge. Is we are part of big organization that is in Denver, and Denver is 4 hours away from Basalt, Colorado. And we are just new in their organization, so we are implementing their EMR, and we have a lot of challenges try to get through the whole system. Seems to be that they haven't even a super user trained in Denver for the organization. So there is many questions about the capacity of the EMR and the challenges that we have for the reporting, for example. So we are in that process of trying to figure out how to communicate better with the provider for the EMR system, and how to get the processes and the templates that we want to have in our clinics uploaded so we are able to use them. But it's it's a big challenge for us because we are very small and we are far away from Denver, so we are not as crucial for them as the people in Denver. I don't know if you don't understand that. So that's our challenge right now.
That sounds like quite a challenge.
Yes.
So, so you're having a problem getting your needs met or your changes made because you're part of a larger organization that purchased this EMR system.
Yes.
You have to go through them before you get to the vendor.
Yes. And
Gotcha.
the system is a really amazing system if you know how to customize it. It's really good. We have some medical practices in the valley in our area that really use the same system and they have it customized for everything that they need, and it works really well. The problem is when you have a system that is really good, but you are not utilizing to its full potential or the full capacity that you can. So we are facing several challenges. For example, I am from a school-based health center, and we are participating in the school-based health center improvement project with New Mexico. And the data that I need to present or that I need to report to Wellington, I'm not lying you. I have to pull 5 reports from my EMR system and then try to play around with those reports so I can collect the information that I have to. Even there, 50% of the data I have to enter by hand because there is no way that I can pull a report that is going to give me the complete information.
Wow, yeah, that sounds frustrating. Is there any chance you would have access to any kind of direct access to the vendor support?
Well, I'm looking for that. I'm trying. I'm trying to be very cautious on the way that I'm asking for those things because I don't want to overwhelm our sponsor. They extend their hand for us, and I don't want to overwhelm them with all the requirements that I want or that I want to have in the system. But that's something that we are trying to talk about, making them see that because of the meaningful use and all these improvement projects that we are participating in, it's very important for them to really be more flexible about what needs to be collected and how to collect it. It seems to be that our small clinic is more advanced, is like going forward faster than them. So I'm trying to figure out how to talk to them and see that we are trying to improve the whole quality, not only of our clinic, but from their clinics in Denver. So it's a little bit of challenge and conversations that we have to get through little by little.
Wow, yeah, thank you for sharing that. That's a challenge you have in front of you. It sounds like you're attacking it from the right angle, though. You're taking the politics into account and all the parties into account and outlining exactly what your needs are and how it will improve your process and your system. So, yeah, the only thing I could suggest maybe is just prioritize exactly what you need to happen in that EHR and just go for the big ones, go for the changes that really absolutely need to be made right away, and then go for the other ones later down the road.
Later down the road, yeah.
But
thank you.
Do you know if
Go ahead.
do you know if the your sponsor is doing any sort of quality improvement work, or has someone that they're working with that might be kind of pushing them to use their EHR to a fuller capacity that you could maybe kind of work through?
Yeah, well, it seems to be that we are that piece of the organization that is trying to do that effort of making them realize how important it is to be able to realize the system. My supervisor, that is the director for community services in Rocky Mountain Youth Clinics, that is our sponsor, is the one that has been trying to push that into the administrators. The problem is that the administrators, they don't really comprehend the different areas of the EMR. So it's really hard to get through that through them, so they really understand why things have to be changed and why it's so important to start tracking some data that is very meaningful for the whole process that we are going through right now. Um, I think that is more about conversations, and it's something that they start doing a few years ago, and we came along a year ago with them. So we are in the midst of them realizing what is important, how to track it, and we are pushing them to go faster because we are already in this improvement project. So I think that is just part of the whole learning experience for everybody.
Yeah, and join the club. It's a learning
Yeah.
experience for all of us because this whole thing is very, very new. The technology is new, the software is new, and the criteria are new. So we're all trying to adapt and make all this work. So, kudos to you for pushing ahead with this. It's pushing against the grain a little bit, but we all have to kind of do it. And
Yes, we have
you're leading the way.
Thank you. That's what I wanted to share with you guys.
Thank you.
Good afternoon. This is Liz. The community of Laguna was awarded a SAMHSA project launch cooperative agreement, and so part of the big process is going to be utilizing an electronic health record system to align our collective impact between the early childhood program, elementary school, our tribal behavioral health, and IHS. So we're very new to this process and excited about getting started.
That does sound exciting.
Have you decided what EHR that you're going to use for that?
We have not. Our providers are very familiar with the EHRs that they use, and so we may just utilize something that's already in place and kind of go from there. We have not assessed the EHR process yet. We literally just we're at such an early stage that we're putting together a council to help with those decisions.
Excellent. Have you contacted the Health Information Technology Resource Extension Center?
I'm not familiar with that, so that's a resource I'd like to look into.
I would definitely, this is a perfect time for you to contact them and just tell them exactly what you're doing, the grant you have, where you're trying to go, even the vendors you have in mind. They're going to be a huge resource for you.
Can you please repeat that, who the resource is?
It's on the slide right now that I'm showing, on the resources. It's called the New Mexico Health Information Technology Extension Center.
Very, very cool. Okay.
And yes, and they are very cool.
Right.
Get in touch with those guys, and yeah, it's a great bunch of people, and that's what they do. They want to make sure that HIT in New Mexico is as good as it can possibly be.
Great. Thank you.
No problem. Thank you for sharing that. That's interesting.
Yep.
Well, without further, I'm sorry. Go ahead.
No, it is interesting, and like I said, we're so early into it. I don't have much to kind of elaborate on.
Understood. I imagine you're a little overwhelmed.
That's an understatement, but yeah, we're excited and equally overwhelmed.
Push forward. This is good stuff. If there aren't any other questions, and please feel free to send those over to me. If you do have some kind of as an afterthought, we'll go ahead and close this out. And I wish you all luck in your HIT endeavors, and keep pushing forward. We're all going to get there, but it's going to be a little bit painful. So I'll leave you with that positive note. And you all have a great afternoon, and we'll start up the series again next semester, and we'll see kind of what we want to do next semester. Definitely be modifying this series to some extent, hopefully be adding on some things as well. So we'll see you next semester as far as this goes. We also have other webinars that we're doing for the next couple of weeks before school ends. So go to envisionnm.org to our calendar. and sign up for any that you might be interested in. Thanks so much for joining us.